friends. I welcome you all to this online class. Today I am going to discuss a topic which is most taught in gynecology and most asked in the examination, that is pelvic organ prolapse. As the name suggests, pelvic organ prolapse is defined as descent of pelvic organ from its normal anatomical position. Prolapse of one or several pelvic organs is a condition that has been known since early days. Pelvic floor defect is caused by childbirth and are caused by stretching and tearing of pelvic fascia, levator and eye muscles and perineal body. Pregnancy itself without vaginal birth has been cited as a risk factor as well. So there are different risk factors and etiologies for pelvic organ prolapse, of which obstetrical risk factor is the most important risk factor. Other one is increasing age, especially after menopause, congenital weakness of pelvic floor muscles, connective tissue disorder, racial differences, and increased intra-abdominal pressure, which is one of the most important causes, and hysterectomy per se. Discussing one by one the different risk factors, of which obstetrical risk factor is the most important, it consists of multiparity. Multiparity increases risk 1.2 times with each vaginal delivery. Reduced birth spacing because it precludes prepuceral rehabilitation. Prolonged second stage of labor and prolonged bearing down effort. Bearing down before full dilatation of cervix, that is premature bearing down. Resumption to heavy work soon after delivery. Delivery of macrosomic baby, anal sphincter or perineal lacerations, epidural analgesia and instrumental delivery. Increasing age between 20 to 59 years, incidence of pelvic organ prolapse roughly doubles with each decade. This is because of degenerative changes and because of hypoestrogenism, because the pelvic structures, muscles, fascia, connective tissue, they all are estrogen sensitive. Congenital weakness of pelvic muscles result in congenital prolapse of newborn, all nulliparous prolapse. Connective tissue disorders result in 1/3 women with Marfan syndrome and 3/4 of women in Ehlers-Danlos syndrome. About racial differences, black and Asian women show lowest risk, while Hispanics have the highest risk, due to difference in collagen quality and quantity and in the structure of bony pelvis. About increased intra-abdominal pressure, chronic obstructive pulmonary disease like asthma, chronic constipation, obesity, repetitive heavy weightlifting, these all result in chronically increased intra-abdominal pressure and predispose to pelvic organ prolapse. Hysterectomy also predisposes to prolapse of vault, because especially when vault is not supported at the time of surgery. Regarding pathophysiology, before going for pathophysiology of pelvic organ prolapse, we must know what is the normal support of uterus and what is the normal support of vagina. So, discussing the normal supports of uterus and vagina, the supports of uterus first, the three structures, muscular, ligamentous and the uterine position, these compose the main support of the uterus. To understand the normal musculature of the pelvis, I would like you to see a video which I am going to show.
Pelvic floor. So what we're looking at here is a superior view into the pelvis, and you can see these muscles which make up the pelvic floor at the bottom of the pelvis. So I've got the femurs in here because I've included the muscles of the walls of the pelvis. So you've got the piriformis muscles attaching to the sacrum and to the greater trochanter of the femur, and you've got the obturator internus muscles, which you can see here. If I rotate round to the back, you can see the tendon of the obturator internus muscle attaching to the femur. So those two muscles make up the walls of part of the walls of the pelvis. So the pelvic floor separates the pelvic cavity above from the perineum below, and it consists of the pelvic diaphragm, and then you've got the perineal membrane and the deep perineal pouch. So the word pelvic diaphragm is often used interchangeably for pelvic floor, but in this tutorial I'm going to talk about the pelvic diaphragm in relation to two specific muscles, and then I'll go on to tell you about the perineal membrane and the deep perineal pouch. So these three structures combined make up the pelvic floor. So to begin with, I'm going to talk about the pelvic diaphragm. So the pelvic diaphragm is this dome-shaped set of structures which we're looking down at, and it consists of the levator ani muscles on either side. So you've got this midline raphe, this ligamentous midline where the two halves of the levator ani muscle attach, and you've got the coccygeus muscle, which is this muscle here. So I've just isolated the pelvic diaphragm muscles, and you can see the shape of them here. It's like this bowl shape of muscles. So ignore this extension up here, as the muscle doesn't actually extend this far up, so just bear that in mind. So it has its anterior attachment on the posterior surface of the pubis here, and then it attaches along the fascia of the obturator internus muscle, and then at the back it attaches to the coccyx, and it meets in the midline to form this midline raphe. So this is where the levator ani meets in the midline, posterior to the anus, which is this aperture here. So anteriorly you can see that the levator ani muscle has this defect. It's got this U-shaped defect, and this is called the urogenital hiatus, and this allows the urogenital apparatus to pass through the pelvic floor into the perineum below. So in males you get the passage of the urethra, and in females you get passage of the urethra and the vagina through this urogenital hiatus. And as you can see, the muscle consists of various different fibres. So you've got these loops of fibres which loop around various structures. So the levator ani muscle is typically thought of in terms of three sets of fibres. So you've got the pubococcygeus, which attaches from the bony bit of the pubis and extends back to the coccyx. So you've got the coccyx at the back here. And then it's got the anterior fibres of the pubococcygeus actually loop around the prostate in males and the vagina in females. So you've got these anterior fibres which are divided and loop around the prostate in males, forming the levator prostatae or the puboprostaticus, and in females it loops around the vagina, forming the pubovaginalis. And then in the midline, as I mentioned before, connecting from the coccyx down to the anus. So remember, this is the aperture for the anus. So connecting from the coccyx to the anus, you've got this midline raphe, this ligament, which is called the anococcygeal ligament or anococcygeal body. And then the next part of the levator ani muscle is this puborectalis muscle. So I'm going to draw this on in green, outline it in green, and this forms a sling around the distal end of the gastrointestinal tract, so around the sort of anus and rectum, around the anorectal junction. So you've got this sling of muscle from the levator ani forming around the anorectal junction. So these are the intermediate fibres of the levator ani, and they again originate on the pubis, and they have the important function of maintaining this anorectal angle. So they keep this angle of 90 degrees, which closes off the anal canal, and I'll come on to talk about this in a moment. And then we've got the posterior fibres of the levator ani muscle, and these are called the iliococcygeus muscles or fibres. So you've got these, which I'm outlining in purple. So those are the three collections of fibres which make up the levator ani muscle. So this muscle forms the bulk of the pelvic diaphragm. So just to quickly recap, the levator ani is composed of these three collections of muscle fibres, and if we rotate the model around, you can see the origin of the levator ani on the posterior surface of the pubis, and then it's got this origin along the border of the obturator internus muscle. So covering the obturator internus is this fascia, and you've got this thickening. So you can see this white thickening. This is a tendinous thickening called the tendinous arch, and this is the thickening of the fascia where the levator ani takes part of its origin. And then over here we've got the ischial spine. So along this line, from the body of the pubis, along this tendinous arch to the spine of the ischium, the ischial spine, the levator ani takes its origin. And then it inserts on the coccyx and in the midline at this anococcygeal ligament. So if we just rotate to an inferior view, you can see these muscles taking their attachment on their little coccyx, and you've got this perineal body, which is a fibromuscular connective tissue node which joins the perineum and the pelvic floor, and you've got some convergence of the levator ani muscles on this node. So the function of the levator ani muscle is to support the pelvic viscera, and it keeps the rectum and vagina closed, so it has this kind of sphincter closing action on the rectum and the vagina. And importantly, it resists rises in intrapelvic pressure during any straining. So for example, during coughing, when the abdominal muscles increase the intrapelvic pressure, it resists this rise and prevents anything being evacuated from the digestive tract. The deep perineal pouch and the perineal membrane. So inferior to the pelvic diaphragm, you've got this membrane which is called the perineal membrane. So you can see this sort of triangularly shaped structure here, which I've outlined in green, and this is a thick fascial structure which attaches along the pubic arch. So you've got this attachment along the pubic arch here, and at the back it's got this posterior border which is free, so it's not attached to anything. So this membrane actually provides attachment for the roots of the external genitalia, and I'll come on to talk about this in another tutorial on the perineum. But importantly, it's got these two holes to allow structures to pass from the pelvic floor into the perineum. So this is a model of a woman, so you've got these two holes here. Anteriorly you've got the urethral orifice, and behind it you've got the vaginal orifice. But in males, obviously, you don't have this orifice for the vagina. So you've just got the anterior urethral orifice in males. So if you remember, I mentioned the urogenital hiatus of the pelvic diaphragm, so that U-shaped defect. So above the perineal membrane you've got this urogenital hiatus. So if I just rotate the model anteriorly again, you can see that there's this little gap between the anterior border of the perineal membrane and the pubic symphysis. So you've got a little gap here. And if I rotate back to the superior view, you can see the urogenital hiatus here and the parts of the perineal membrane with the two orifices for the vagina and the urethra. So I've just added the female reproductive system in, and you can see the vagina entering into the pelvic cavity through this vaginal orifice in the perineal membrane. And with the urinary system added in, you can see the bladder and you can see the urethra here. So the last part of the pelvic floor to mention is the deep perineal pouch. So the deep perineal pouch is this fascial capsule which lies above the perineal membrane, and this contains various layers of skeletal muscle which differ between men and women, and all the muscles in this compartment are innervated by the perineal branches of the pudendal nerve. So what I'm going to do is I'm going to switch to a cross section to try and illustrate the deep perineal pouch. So what I've done here is taken a median sagittal section of this model. So if I just rotate inferiorly, you can see that I've sliced in half the perineal membrane. So if I just rotate round laterally, I'll show you what we're looking at. So we've got the layer of levator ani muscles here, so the pelvic diaphragm above here superiorly, and then just below it we've got the perineal membrane. So between the pelvic diaphragm muscles and the perineal membrane you've got this deep perineal pouch. So it lies like this, and it's actually open above, so there's no there's no layer separating the pelvic diaphragm muscles from the perineal pouch. So you've got this fascial pouch, which I've drawn in green, and it's open superiorly. So like I said, you've got a few different structures within this pouch, and they're innervated by the perineal branches of the pudendal nerve, and they're different in men and women. So what I'm going to do is show you some of the structures that are within this perineal pouch, this deep perineal pouch. So we're back to this superior view of the pelvis, which you're familiar with, and I'm just going to dissect away the pelvic diaphragm muscles. So I've got rid of those muscles, and we're looking superiorly at the perineal membrane. So the contents of the pouch sit on top of this in this fascial pouch. So remember, we're looking at a model of a woman, so we've got the vaginal opening here, and we've got the urethral opening anteriorly. So first we'll look at the muscles in the female, because they've got two more muscles than men. So we've got this free border of the perineal membrane at the posterior aspect, and in the midline we've got this little body called the perineal body, which is a fibromuscular connective tissue node which connects the structures of the perineum to the pelvic cavity above, the pelvic floor above. So the first muscle that we have is this deep transverse perineal muscle. So it attaches laterally on the ischiopubic ramus, and it inserts onto this perineal body in the midline. So that's the deep transverse perineal muscle. And then over here you can see this little muscle here. This is the external urethral sphincter, and this surrounds the proximal part of the urethra in women and the membranous part of the urethra in males. And then we've got two muscles which are unique to females. So we've got the compressor urethrae, and then we've got the sphincter urethrovaginalis. So the compressor urethrae originates from the sides of the ischiopubic ramus, and then it loops in like this and meets anteriorly to the urethra. So you've got this compressor urethrae muscle, and it meets anterior to the urethra. So this muscle aids the external urethral sphincter in closing off the urethra. And then you've got this muscle called the sphincter urethrovaginalis, and as the name suggests, it forms this kind of sphincter around the opening of the vagina in the perineal membrane, and it also blends with these fibres here, so it surrounds the opening of the urethra as well, so urethrovaginalis. So this originates on the perineal body at the back, and then it passes forward surrounding the opening of the vagina, and then it blends anteriorly with the muscles surrounding the urethral opening in the perineal membrane. So in men you've just got the deep transverse perineal muscle and the external urethral sphincter. And something else to remember in males is that within this deep perineal pouch you've also got these glands called bulbourethral glands, which are also known as the glands of Cowper. So they lie within the deep perineal pouch.
So you have understood in a better way the levator ani muscle and its parts, and how it forms a diaphragm in the pelvic floor, preventing the descent of pelvic viscera. So it is now clear that levator ani has three parts from anterior to posterior. The anteriormost part is pivococcygeus, and then the iliococcygeus, and posteriorly ischiococcygeus. Pivococcygeus again has two parts, pivovaginalis and pivorectalis. Pivovaginalis loops around the vagina, and pivorectalis loops around the rectum at the anorectal junction. The ligaments provide strong support as they are tough structures and form a sling around the level of the internal os, and also attached to the vaginal fornices, attaching them to the lateral pelvic wall on all sides, that is anteriorly through the pubocervical ligament, laterally through the cardinal or transverse cervical or McEnroe's ligament, and posteriorly through the uterosacral ligament. Thus it holds the uterus and the apex of the vagina in its place, and preventing their descent during strains of raised intra-abdominal pressure. The third mechanism of preventing descent of uterus from its anatomical position is by virtue of its position. The normal position of uterus is that of anteversion and anteflexion. The anteversion of the uterus is the angle between the axis of the vaginal canal and axis of the cervical canal. This is about 90 degrees. So the cervix is at 90 degrees to the axis of the vaginal canal, and again this is angle of anteversion, and again the uterine body is flexed, slightly flexed over the cervix at the level of internal os, and this is known as an angle of anteflexion. So the body of uterus makes an angle with the axis of the cervical canal. This is angle of anteflexion. So altogether it is in the curvature is in the form of a C, and whenever there is raised intra-abdominal pressure, the pressure is transmitted so that the uterus and the cervix are pushed against the vaginal canal instead of getting into the vaginal canal. So the picture on the right side is showing what will happen if the uterus, instead of being anteverted, gets retroverted. So when it is retroverted, it comes in line with the canal of the uterine axis. The axis of the uterine canal comes in line with the axis of the vaginal canal, and thus any raised intra-abdominal pressure pushes the uterus and the cervix down into the vaginal canal, producing prolapse of descent of the uterus and cervix. Coming to the vaginal support, D. Lancey described vaginal support into 3 levels according to the support of the upper, middle and lower 1/3 of the vagina. So upper vagina is supported by cardinal uterosacral attachment of the cervix and upper vagina. Together they allow the vagina to be supported on the levator plate, maintaining its length and horizontal axis, and positions the cervix just above the ischial spine. Defect in this support leads to apical prolapse or entrocele. This picture shows the normal axis of uterus, vagina and the levator plate. You might remember from the anatomy of levator and eye muscle that the muscles of the two sides meet in the midline posterior to anus and extend to the coccyx. This tough fibromuscular raft is called levator plate. When the muscles on either side have good tone, it keeps the levator plate, this is the levator plate, it is stretched down and in horizontal position. But when the levator tone of the levator and eye muscle is weak, the plate becomes loose and comes forward. So in this picture, the good tone of the levator and eye muscle maintains the levator plate in almost horizontal position, and therefore the structures which are resting over it, the upper part of the vagina and the rectum, they are also in almost horizontal position. But when the tone of the muscle is lost, the levator plate becomes vertical, bringing along with it the rectum and the upper part of the vagina and making them vertical too. In this way, lost tone of levator and eye makes the levator plate as well as vagina and upper vagina almost vertical. It favors the descent of uterus and cervix into the vagina whenever there is raised intra-abdominal pressure. The uterus and cervix are pushed inside the vaginal canal, producing prolapse. The level 2 support is paravaginal or lateral vaginal connective tissue attachment to arcus tendinous fascia pelvis. Its detachment leads to lateral and anterior vaginal wall prolapse. And the level 3 supports the lower 1/3 of the vagina. It consists of perineal body, superficial and deep perineal pouch muscles. Damage leads to, it supports the distal 1/3 of the vagina and introitus. Damage leads to distal anterior and posterior vaginal wall prolapse, gaping introitus and perineal descent. Now coming to classification of the pelvic organ prolapse. There are various ways to classify pelvic organ prolapse, but the most popular and most practiced is Shaw's classification. Shaw has classified uterovaginal prolapse into 3 compartments: the anterior, the middle and the posterior. The anterior vaginal wall prolapse again is divided into upper 2/3 and lower 1/3 vaginal wall prolapse, and the posterior vaginal wall prolapse into upper 1/3, middle 1/3 and lower 1/3 vaginal wall prolapse. this is according to the structure which the vaginal wall supports. Like upper two-thirds supports the bladder, so its descent brings bladder along with it into the vaginal canal. This is known as cystocele. Lower one-third supports the urethra, and it's the descent of the lower one-third of the vaginal wall brings urethra along with it. This is known as urethrocele. Likewise, posterior vaginal wall prolapse in the upper one-third supports the pouch of Douglas posterior to it. Pouch of Douglas contains the loops of a small intestine, and when there is weakness of the upper one-third of the posterior vaginal wall, it laxates, protrudes inside the vaginal canal, bringing the peritoneum and the loops of small intestine along with it. This is enterocele. Middle one-third supports the rectum and produces rectocele, and lower one-third supports the perineum, and its weakness results in deficient perineum. Regarding uterine prolapse, Shaw's classified into 4 degrees. The first degree descent is descent of cervix below ischial spine, because cervix normally is placed at the level of ischial spine but is above the introitus. In second degree descent, descent of cervix is up to the introitus. Third degree descent, that the cervix comes beyond the introitus, and in fourth degree descent or precedentia, whole of the uterus is prolapsed outside the introitus. Thus, introitus here is taken as the reference point for grading or classifying prolapse. This picture very well shows the different degrees of prolapse. The first on the left is the normal position of the uterus, where the cervix is well supported at the level of ischial spine. This one is showing the level of the cervix is below the level of ischial spine, but it is above the introitus. So this is first degree uterine descent. The second is cervix comes up to the introitus, that is, this is the second degree descent. In the third degree descent, the cervix comes beyond the level of introitus, and in the fourth degree, whole of the uterus is prolapsed outside the introitus. So this is precedentia or complete prolapse. Another is Baden-Walker halfway system. This is also a simple way of classifying pelvic organ prolapse. Here there are 4 grades. Grade 0 is normal position. Grade 1 is descent halfway to the hymen. Grade 2 is descent up to the hymen. Grade 3 is halfway past hymen, and grade 4 is maximum possible descent for each site. Descent of anterior vaginal wall, posterior vaginal wall, or apical prolapse can be graded with this system. Here also hymen is taken as the reference point. Points above hymen. If this is the reference point, that is hymen, and this is the level of ischial spine, which is taken as 0 position. So between 0 and hymen, the space is divided into 2 halves. So up to half from ischial spine, this is grade 1 descent, and from half up to hymen is grade 2 descent. Likewise, beyond the hymen up to maximum descent, the space is divided into 2 halves. This is from hymen halfway up to maximum descent is 3rd grade, and beyond that is grade 4. So these two systems, the Shaw's and the Baden-Walker halfway system, were very subjective, and inter-observer variability was there. So it was non-reproducible. Therefore, a quantitative system was devised, and this is known as pelvic organ prolapse quantification system, or POPQ in short. In this system, there are various points on the anterior vaginal wall, the posterior vaginal wall, on the cervix, and on the posterior fornix. So let us try to understand each point one by one. Point AA. So there are 2 points AA and BA on the anterior vaginal wall. This is the anterior vaginal wall. Similarly, there are 2 points AP, corresponding points, and BP on the posterior vaginal wall. So point AA is a point located in the midline of the anterior vaginal wall. Point AA is a point located in the midline of the anterior vaginal wall, 3 cm proximal to the external urethral meatus. External urethral meatus, 3 cm proximal to it. The potential range of the position of point AA is relative to the hymen is -3. So all the points above the hymen. Hymen here is taken as reference point and is denoted as 0. And all the points above the hymen are taken as negative, and all the points below hymen are taken as positive. So A is a point which is above hymen and 3 cm above hymen, so it is indicated as -3. So it can be when there is maximum prolapse of point AA, it will descend 3 cm beyond hymen and it will become +3. So its range of AA is from -3 to +3. Similarly, the point AP, it ranges from -3 to +3 on the posterior midline of the posterior vaginal wall. Now come to point BA. Point BA represents the most distal or most dependent position of any part of the upper anterior vaginal wall between vaginal cuff or anterior vaginal fornix and point AA. So it is the most dependent position of any part of the upper anterior vaginal wall between the vaginal cuff or anterior fornix and point AA. Point BA coincides with point AA, that is -3 centimeters, when the woman has no anterior vaginal wall prolapse. In a woman with severe prolapse, BA will coincide with point C. We will see in later pictures how this happens. Now come to point C. Point C, it is either on the most distal, that is most dependent edge of the cervix, or the leading edge of the vaginal cuff in hysterectomized women. So if she has undergone hysterectomy, so this will be C will be a point on a most leading edge of the vaginal cuff. Point D is a point on the posterior fornix in a woman who still has a cervix. Point AP and BP correspond to those on the AA and BA on the anterior vaginal wall. So BP again is a point that represents the most distal portion of any part of the posterior upper vaginal wall between vaginal cuff or posterior vaginal fornix and point AP. So there are 3 further descriptive landmarks and measurements. One is GH. GH is genital hiatus. Genital hiatus is measured from middle of the external urethral meatus, midline of the posterior margin of the hymen. PB is perineal body. It is measured from the posterior margin of the hymen to the mid-anal opening. This is perineal body. And TVL is total vaginal length. Total vaginal length. Length of vagina in centimeters from posterior fornix up to hymen when point C or D is reduced to its full normal position. So in a hysterectomized patient, point C makes the uppermost part of the vaginal cuff. So in fully reduced position from point C or point D up to the hymen makes the total vaginal length. Total vaginal length is the only measurement which is taken in a relaxed and fully reduced prolapse. Relaxed position and in fully reduced prolapse. Point D is included as a point of measurement to differentiate. Point D, what does this point D denote? It is taken to differentiate suspensory failure of uterosacral cardinal ligament complex. Uterosacral cardinal ligament complex from cervical elongation. When the location of point C is significantly more positive than location of point D, this is indicative of cervical elongation, which may be symmetrical or eccentric. Point D is omitted in the absence of cervix. How is this the examination POPQ is performed? It is performed with an empty bladder and if possible an empty rectum. A full bladder is potentially associated with underestimation of POPQ severity. So any position that best demonstrates the maximum extent of prolapse and which can be confirmed by the woman by digital palpation. There are 6 different points that are considered while recording POPQ: AA, BA, C, D, AP and BP. The position of these 6 defined points are measured during maximum Valsalva. If the point descends to the hymen, it is measured as 0 and it remains above hymen, it is measured in centimeters and described as negative, and if it is beyond hymen, it is measured in centimeters and described as positive. So all the above measurements are recorded in a 3x3 grid. The anterior vaginal wall and the cervix or wall are documented on the top row. BA, A and C. The anterior vaginal wall points are recorded on the top row. The posterior vaginal wall and the posterior fornix on the bottom row. GH, perineal body and total vaginal length are recorded in the middle row. After recording in a 3x3 grid, depending upon the measurements, prolapse of each of the compartment is staged. Prolapse of each compartment is staged based on its relationship to the hymen. Coming to staging, so stage 0 is no prolapse. That is, all the points are at their normal position. Stage 1 is most distal prolapse is more than 1 centimeter above the level of hymen. That is, point AA and BA has descended from -3 up to -1, but not beyond -1. So this is the most distal prolapse is above -1. Then this is staged as stage 1. Then stage 2 prolapse, when most distal prolapse is between 1 centimeter above and 1 centimeter below hymen, that is between -1 to +1. Stage 3, where most distal prolapse is more than 1 centimeter below the hymen but not completely everted, meaning no value is not completely everted. No value is more than or equal to total vaginal length -2 centimeters. In stage 4, there is complete eversion or eversion to within 2 centimeter of total vaginal length of lower genital tract is demonstrated. Any of the points, that is BA, C, D or BP, is more than or equal to total vaginal length -2 centimeters. So this figure shows the prolapse of the anterior vaginal wall. Here you can see that AA has descended from -3 to 0. This is the level of hymen. And BA, which should normally correspond to AA in a woman with no prolapse, it has also descended to 0. So AA and BA values are 0. So they have come up. Similarly, in the posterior vaginal wall prolapse in this picture, AP has descended from -3 to 0, that is up to hymen, and BP, the most distal part of the BP, has come to touch the hymen, that is, it has also come to 0. So here there is second stage anterior and this is second stage posterior vaginal wall prolapse, and this is showing total prolapse. This is complete procedencia because all the points have come beyond the level of hymen. 2 and C and D has protruded up to maximum possible extent. So total vaginal length, that is in the reduced position up to D, is 10 centimeters. So this is comparison has come to +3 from -3, and BA, BP and C are almost corresponding to +8. So this is how this staging of system POPQ is done. But POPQ is, although it is quantitative and reproducible, inter-observer variability is less. It is a little complex. It is not that easier. Next we come to the symptoms of pelvic organ prolapse. Pelvic organ prolapse mostly are asymptomatic, and if there are maybe of bulge symptom, urinary symptoms. So bulge system is some symptom is most common complaint of the patient, of such patients is something coming out per vaginum, sensation of fullness in the vagina, heaviness in the pelvis or vagina, and urinary symptoms include incontinence, urgency, frequency, feeling of incomplete evacuation, and bowel symptoms include feeling of incomplete evacuation, constipation, digital compression of posterior vaginal wall in order to defecate, incontinence of flatus or stool. Sexual symptoms may be dyspareunia or decreased lubrication. There may be pain in the vagina, bladder or rectum, or pelvic pain, or chronic, dull, low backache. What are the signs on examination you may get? So assessment of prolapse, it is usually done in dorsal lithotomy position or dorsal position. Look for stress incontinence in full bladder first before asking the woman to empty her bladder. Look for stress incontinence. Then the patient is asked to strain and perform Valsalva to assess stress incontinence. Then the patient is asked to empty her bladder, and in relaxed position total vaginal length is measured, and then she is asked to strain, and one by one the anterior vaginal wall descent and the posterior vaginal wall descent and cervical descents are noted. Vulval examination for perineal laceration, 3 compartment evaluation separately, and decubitus ulceration, these all are noted. Pelvic floor muscles are also assessed. Pubococcygous part of levator and eyes is assessed at 4 and 8 o'clock position. Then perineal body, the thickness and the length is noted, and rectal examination, that is tone of anal sphincter, is assessed. The differential diagnosis of pelvic organ prolapse include vulval cyst or tumor, cysts of anterior vaginal wall, urethral diverticulum, congenital elongation of cervix, vaginal portion of cervix is elongated, no vaginal prolapse, and D fornices are found. That is, C is descended but D is at its normal place. Cervical fibroid polyp and chronic inversion of uterus. So what prophylaxis should be taken in order to prevent pelvic organ prolapse? Because it is mainly related to pregnancy and childbirth, all precautions should be taken during pregnancy and childbirth. That is, antenatal exercise, due attention to weight gain and anemia, preventing prolongation of second stage of labor and premature bearing down effort, proper use of episiotomy and low forceps. Episiotomy use is where it is required. It is not mandatory in all the cases of delivery. Suture perineal tear, postnatal early ambulation and physiotherapy, adequate birth spacing, avoid multiparity, prophylactic HRT, that is hormone replacement therapy in postmenopausal women, because it is also related to estrogen deficiency. And regarding the treatment, continue with management of pelvic organ prolapse in my next video. Thank you.